nice introduction, and thanks for SPART team for inviting me for this very well organized, and thanks for the hospitality. My pleasure to be here in my home country in Slemania and see my students also who are now an oncologist, Dr. Howard, Dr. Rebaz, they are here. It will be difficult to cover the topic in very short time, in 12 minutes, but I will try to give some practical point in the thyroid cancer. So this is the outline my presentation, talk about shortly about epidemiology, radioactive and risk assessment of thyroid cancer, systemic therapy, and case presentation, then the take-home messages. The epidemiology of thyroid cancer different in different areas, and you can see that in our area, the Iraq and the Middle East, it's in the range between 3 to 5 per 100,000 of the population, which is a bit lower than other areas like Asia or America. And this is data from Qatar. We can see thyroid cancer, the third common cancer. It is a very high incidence in the area, and this is mainly because we have many Filipino, and thyroid cancer in female Filipino is very high. We see a lot of young patients having thyroid cancer. And you see the age of these patients, majority between the age of 20 and 40. Majority of them are young patients. This is the global data. We can see thyroid cancer is the sixth common cancer in incidence. The incidence is high, but we see the mortality is down in the list. You know, most of the differentiated thyroid cancer having good prognosis and they have good survival. So the mortality is lower than the incidence. And you can see the number of cases is ranking 7 in incidence, but in mortality it is 24. In Iraq, we can see that we have some data. This is the number of cases, 37,000, and prevalence in 5 years around 100,000, and mortality is 21. So again, it is lower than the incidence, much lower than the incidence. And again, we can see the incidence. This is in both sexes. Thyroid cancer is coming down in the list. It is 7 or even not from the common cancer in the area, and incidence is high, while the mortality is much lower than that. Now in females, we can see again in Iraq even it is third common cancer. Again, it's like Qatar, so it is similar to the other Middle East country. It is a high incidence in female, and this is maybe related to other factor having more goiter to the iodine deficiency in these areas. This is data I got from Dr. Hauro. This is from our area from Kurdistan region, and we can see thyroid is the 10th common cancer in the area. Again, this is in both sexes, but if we see the female, it says 206, so it's coming nearly in the 4th or 5th common cancer. Again, it is much higher in a female patient, very similar to the international data. It is not changing. Okay, so the origin of thyroid cancer, either from epithelial follicle, as we heard from Dr. Sarbar, or from the C cells, which are the medullary thyroid cancer. The differentiated thyroid papillary, which is the most common, around 70%, follicular, around 15-20%, and the fertile cell, also a differentiated thyroid cancer. And we have the poorly differentiated anaplastic, which is the percentage of these cases, as we hear that is increasing by the histopathology. We can see which type of cancer. Previously, before 2012, we don't have only surgery and radioactive iodine. This is the old thing can be done for thyroid cancer cases, surgery, or if your patient need radioactive iodine, in addition to the thyroid suppression, otherwise it will be observation and nothing more than for that will be done for the patient. And the history of radioactive iodine back to credited back to Madame Curie, and long time ago, more than 200, when she discovered the radioactive material and the radioactive iodine. There are different forms, and the most common is the 131, which is used for diagnostic and therapeutic purposes for thyroid cancer cases. Now the overall survival for thyroid cancer is very good for the differentiated one, especially you see disease-specific survival around 98%, while if you have lymph node metastasis or extrathyroid extension, usually the incidence is lower. This is the most important slide. We have to classify the patient with thyroid cancer, differentiate one, low risk, high risk, intermediate risk. For the low risk, usually the recurrence rate is very low, 5 to 10%, while intermediate 5 to 20%, intermediate divided into the high intermediate or low intermediate, and we have the high risk group. This is the important group of patients, and this is also important because your radioactive iodine will depend on this risk assessment to give a low dose iodine, 30 millicurie, or give the high dose radioactive iodine, which is around 100 millicurie. This is very important, and we see the high risk group are those patients with follicular type, with incomplete tumor resection, distant metastasis, elevated post-operative thyroglobulin. All are these or not positive cases. All these are the high-risk feature, and they need high dose of radioactive iodine. I will not talk about the differentiated one. My colleague, Dr. Imad, will talk about the differentiation or radioactive resistant thyroid cancer cases. He will talk about that. I will concentrate on the other types. This risk assessment according to the American Thyroid Association. Okay, so for the adjuvant radioactive iodine, for the low risk, usually the risk of recurrence low, so no need to give no benefit in giving them radioactive iodine. Why? These are the multiple studies that showing that the low risk not benefiting from radioactive iodine. But for the intermediate risk, especially the high intermediate risk, you have to give the high dose radioactive iodine, which is 100 millicurie for these patients. These are the high grade, the third category, which is the incidence of recurrence around 20%. And we can see from this study that when giving radioactive iodine, they benefit from this treatment very much. And in this case, these are different studies, and according to the Thyroid Association, how we can classify those high-risk group of patients. This is a large number of study meta-analysis. All of them show the benefit of giving them high-dose radioactive iodine. Summary, it is the most low risk, no need for radioactive iodine. The high risk, you give the high dose, the intermediate to intermediate dose of this patient. The redifferentiation can occur sometime, even become radioactive, again responsive to the radioactive iodine if redifferentiation can occur in these cases. So future direction is important to expand the knowledge about prognostic value histology and mutation type. Lesion dosimetry is important for radioactive iodine, quantity of the expression, and the manipulate the radioactive iodine differentiation back and on to these cases of the thyroid. Definition of radioactive resistant or refractory is important because those patients who are refractory to radioactive iodine would go for systemic therapy. Now we have systemic therapy, the target therapy of this. These are the criteria for this patient should receive at least 600 millicurie. Then after that, consider resistant to the radioactive iodine, different according to the American Thyroid Association classifying these patients. And you can see how these can be considered according to this treatment. And it is important that we preserve this treatment to later stage, initially just suppression, radioactive iodine, and later when you have metastasis and progression, we'll go for further treatment. These are the different mutations occur in thyroid cancer. Therapy for these cases according to this. This is important to have molecular study for all cases of thyroid cancer to see whether there is BRAF mutation or RET mutation. And again, you have to reserve the systemic therapy because the response usually incomplete. Eventually, all patients will progress on this treatment, and treatment is not free of side effect, financial, and other quality of life impairment with this treatment. This is the refractory. Then we have many drugs approved. That we have the sorafenib, we have the lenvatinib. These are different trials and showing the improvement in the outcome of this patient. We have a lot of side effect from this patient receive, especially sorafenib, foot-hand syndrome, fatigue, hypertension, all these can occur. Same thing with lenvatinib, can have a lot of side effect with this treatment. Now for the RET specific, now just for the last 2 years, 3 years, we have a treatment for when we have RET mutation, and this is the study which is called ARROW study, showing significant improvement of those patients having RET mutation. So it is important to have the molecular study and see the difference between the treatment, whether give a specific anti-RET for these patients. The study for the poorly differentiated and anaplastic thyroid cancer also in the last 2 years. I remember before that I have 3 patients anaplastic, all of them died within 1 month. And my colleague also know that how aggressive anaplastic thyroid cancer. We don't have before that anything. We give chemotherapy, not working, radiotherapy, very limited effect. So it is very important. Now we have studies with showing improvement in these patients. This is the when giving lenvatinib with pembrolizumab for those patients. Disease control rate very high, approaching 80 or 90%. In these cases, simple tablet given orally with an injection every 3 weeks for these patients. Having some side effects, but we have good percentage of response. And these patients, this is the outcome with this study. Now we have many options for treatment for the refractory, and Dr. Ahmad will talk about this treatment. I will go just shortly for 2 case presentation. One of them is the medullary thyroid cancer. This is a young patient presented with blurred vision, just impairment of the vision, and found to have a choroidal lesion. Later on further examination of the patient, they found thyroid mass, and with the imaging show liver lesion, lung lesion, bone metastasis, disease metastasis everywhere. So patient giving stereotactic radiotherapy. This is the choroid lesion. We can see it here. That's why the patient having impairment of vision. This is the ultrasound of the patient. You can see the thyroid gland also enlargement. This is the choroid lesion. This is the lung metastasis and liver metastasis, so the widespread disease in this patient. This is the bone scan, also the pathology show you have total thyroidectomy and show medullary type of thyroid cancer with lymph node involvement, and he has received cyberknife stereotactic radiosurgery to the eye lesion and have improvement on the eye site. And this is the liver lesion. He received a specific anti-RET, which is selpercatinib, 2 years ago. The patient nearly have complete remission. He is perfectly well, doing very well. Before having this sort of treatment, those patients, we don't have much to do. Those patients, they not respond to chemotherapy, not responding to the immunotherapy. The patient is still doing very well. He survived now for a good time. This is the imaging we can see later on. So this is this is the calcitonin, and see after treatment it is still normal now. This is the most recent one, just 2 weeks ago. So this is the outcome. We can see how those patients improved with the systemic therapy. The second patient, this is a young patient also, 42 years, presented with in February 22 with big mass in the neck. This is the ultrasound. We can see how big the lesion in the neck. This is the lesion. Have tried to do surgery, and then when thyroid surgery, they couldn't do anything because attached to the surrounding, they took a biopsy, which is incisional biopsy, and it proved to be anaplastic thyroid cancer. The molecular study showed no mutation. Again, another problem. So this patient received chemoradiotherapy, paclitaxel with carboplatin and radiotherapy, having very good response, nearly achieved. This is before the treatment. You can see the thyroid lesion. He have no metastasis at that time, but after finishing the chemoradiotherapy, this is the ESMO guideline. We can see for anaplastic thyroid cancer, we don't have much to do. If you have no mutation, if you have mutation, you can give the anti-BRAF. If no, just palliative or radiotherapy-based supportive care. But now we have treatment according to the recent study I showed at LIB, giving the immunotherapy with target therapy. This patient was, unfortunately, after finished radiotherapy, he developed brain metastasis. We give him radiotherapy to the brain and then starting on lymphatinib and pembrolizumab. The patient survived for good time, just 1 minute. This is the after radiotherapy. You see the lesion nearly disappeared from the neck, both sides. And this is the brain metastasis with a PET scan can seen. He developed also a para-aortic lymph node, local recurrence, but the patient remained nearly more than 1 year on the lymphatinib and pembrolizumab. This is good achievement for anaplastic thyroid cancer. As I said before, patients surviving 1 month, not more than that. Only thing we can do for them were tracheostomy to have proper breathing. So now we have some option for treatment of these patients. So this is how patients receive treatment. This is the brain metastasis. He had progression. Patient was reluctant to receive more radiotherapy to her brain. Unfortunately, expired nearly about 1.5 years from the starting of the treatment. So my take-home message for thyroid cancer is a not uncommon cancer. Surgery is the main step in the treatment. Choose the radioactive iodine according to the risk stratification is important, and should have a well-defined radioactive refractory disease to start the systemic therapy. Systemic therapy is only in radioactive refractory to start the therapy when clearly indicated, not in all of them, and choose the TKI according to differentiation and the molecular type of thyroid cancer. And thank you for your attention.